So femur extends from hip to the knee, and it is the longest and strongest bone in our body. In axial skeleton, most of you will be asked femur. Okay, very important word for Viva table. Okay, so it is forming the mid portion of the femur is the long cylindrical shaft which arches or curves anteriorly. Okay, this is femur of right side. You can see the shaft of the femur is arching anteriorly. Okay, and at the proximal end, the spherical head of the femur articulates with the acetabulum of the hip bone to form the hip joint. So this part is the articular head of femur. Okay, it articulates with the acetabulum to form the hip joint. This is the pelvis. Okay, this is acetabular cavity. So head of femur will articulate like this with the acetabular cavity to form the hip joint. Okay, and distally the femur articulates with the medial and lateral condyles of the tibia to form the knee joint. All these articulation will be asked during the Viva table. So this is femur of right side. This is tibia of right side. It will articulate like this. Okay, two condyles of the femur will articulate with two condyles of the tibia to form the knee joint. Okay, understood? And the patella covers the anterior portion of the femur's distal articular surface. See, this is patella of right side. Okay, so it will articulate here. This distal articulate anterior part of the distal articular surface of femur. This is patellar articular surface, and this lower part of articular surface is the tibial articular surface. Okay, so this patella bone cover, and it only comes in articulation with femur during extension of the knee. Okay, during flexion of the knee it stands free. Okay, freely movable, and freely it does not come in contact with the femur in case of flexion of the knee. আচ্ছা একটা আচ্ছা ওকে Okay, so patella bone covers the anterior portion of the femur's distal articular surface and helps protect the knee joint from injury. Okay, so see here, this is anterior view of femur, this is posterior view of femur. Important features you see, at the upper end this rounded portion is the head, this part is the neck, it is almost pyramidal shaped neck. Okay, head, neck. Next, this prominence is the greater trochanter, this prominence is lesser trochanter, greater trochanter, lesser trochanter. Okay, and these two trochanters are connected anteriorly via the intertrochanteric line and posteriorly via the intertrochanteric crest, and over this intertrochanteric crest one tubercle is present. This is known as quadrate tubercle. Okay, one muscle is attached, quadratus femoris, you have seen in relation of the hip joint. So this is anterior view, so intertrochanteric line. In posterior view, here is the intertrochanteric crest, and this middle part, elevated part, is the quadrate tubercle. Okay, next, this is anterior surface of the femur. Here are the medial and lateral surface of femur, and this is posterior border. Posterior border is called as linea aspera. Okay, so this bony prominence posteriorly, thick bony prominence, that is known as linea aspera. You will be asked the attachment of the linea aspera, you must know. Okay, next, at the lower end two condyles are there, medial condyle, lateral condyle. Okay, and on the condyles, over the condyles, the most prominent point is the epicondyle. So this is laterally placed, so this is lateral epicondyle, and here is the medial epicondyle. Okay, some ligaments are attached over this epicondyles, and condyles will articulate with the tibial condyles to form the knee joint. And here is the patellar articular surface, it articulates with the patella. And on posterior view, there is one important surface that is known as popliteal surface. And here in the upper one third, this is known as posterior surface. Okay. So in the upper one third, there are four surfaces: anterior, medial, lateral, and posterior. In lower one third also four surfaces: anterior, medial, lateral, and this popliteal surface. Okay, popliteal vessels are lying here, that's why the name is given popliteal surface. And in the middle one third, there are three borders and three surfaces. Okay, anterior surface, medial surface, and lateral surface. Our borders are the medial, lateral, and posterior border or linea aspera. Okay, understood. And other important features, on this side there will be a crest. Okay, and on this side is the gluteal tuberosity. Maximum fibers of the gluteus maximus are inserted over here, 1/4 of the fibers. Okay, and rest were inserted over the iliotibial tract. Previously we discussed iliotibial tract. Okay, so these are the important features, bony features. See here, this pink colored portion is the head. Here is the neck, greater trochanter, lesser trochanter. These are the parts of upper end. And intertrochanteric line anteriorly, intertrochanteric crest posteriorly, quadrate tubercle. Here is the pectineal line. This line ridge is known as the pectineal line. Okay, extending from the lesser trochanter downward. Okay, pectineus muscle is inserted over here, and here is the gluteal tuberosity, and this is the posterior surface. Here will be the quadrate tubercle, linea aspera, and you see here there is a depression near the center of the head, that is known as Fovea capitis. Okay, ligament of the head of the femur or round ligament of the femur is attached over this Fovea capitis. This is very frequently asked, what is the name of this depression and structure attached, and what is the function of this ligament of head of femur? Some arteries are passing through this ligament to supply the head of the femur. Okay, understood? Okay, so and these ridges are known as medial and lateral supracondylar ridges here. Okay, medial and lateral supracondylar ridges, where in the lower part linea aspera is diverging to form this supracondylar ridges. Pectineal line and gluteal tuberosity. Here is the pectineal line, and here this rough elevation is the gluteal tuberosity. Okay, and you can see on the posterior aspect, from you can, if in view from posterior aspect, in between the two condyles there is condylar fossa. Okay, condylar fossa have a lateral wall, medial wall, and the fossa, and in the lateral and medial wall there will be attachment of cruciate ligaments, anterior and posterior cruciate ligaments. These are important ligaments of knee joint. Okay, so this part is the intercondylar fossa, and this is articular surface for the tibia, and here is the anteriorly articular surface for the patella, and these are the epicondyles have been shown, lateral epicondyle, medial epicondyle. Okay, and this is the popliteal surface. Okay, so we will discuss the bony markings first, then the and along with its attachments. Okay, so first is the, we will see the shaft. This is the cylindrical shaft. It is arched anteriorly. Body of the femur is arched anteriorly. Head is prominent. See, this is the head. Head is prominent, smooth, ball-shaped structure on the proximal end of the bone, and the head articulates with the acetabulum of the hip bone to form the hip joint. Okay. Next, and at the center of the head there is fovea of the head of the femur. It is a small pit-like depression on the medial surface of the head, and this is also called the fovea centralis or fovea capitis, and it is an attachment site for the ligamentum teres femoris. Okay, this ligament is very frequently asked. Next we are going to neck. This part is the neck, so this will be the neck. Okay, neck is a pyramid shaped expansion that connects the head to the shaft. Okay, and this region is a frequent site of fracture, especially in the elderly. We have already discussed fracture neck of femur. Okay, 3 types of fractures are there: subcapital, transverse cervical, basal. Okay. Next is greater trochanter. Here is the greater trochanter. This is greater trochanter. It is a large irregular shaped process located lateral to the neck, okay, and superior to the shaft. Superior to the shaft. It is an attachment point for the gluteus medius, gluteus minimus, piriformis, two obturators and gemelli. Okay, so where they are attached, gluteus minimus is attached on the anterior surface of this greater trochanter. Okay, anterior surface gluteus minimus. Or laterally there is a oblique line. This oblique line gives attachment to the gluteus medius, and gluteus maximus is attached to this gluteal tuberosity. So these are the attachment of 3 gluteal muscles. Okay, and this is tip of the greater trochanter. This most prominent upper point is the tip of greater trochanter or apex of the greater trochanter. Here piriformis muscle is attached, okay, over the tip of greater trochanter. Then from tip anteriorly, the superior margin of the greater trochanter gives attachment to the tricipital tendon. Gemellus superior, tendon of obturator internus, and gemellus inferior. Okay, and on the medial surface of this tip of greater trochanter, here is a fossa. This fossa is also very frequently asked. This fossa is known as trochanteric fossa. Here, okay, you have seen trochanteric fossa. Here is the attachment of the obturator externus. Tendon comes lying on the posterior surface of the neck of femur and going to be inserted into this trochanteric fossa. So trochanteric fossa, insertion of obturator externus. So 2 obturator, 2 gemelli, gluteus medius and minimus are attached to the greater trochanter. Okay, understood? You will be asked the attachment where the muscles are attached. Okay. Next we are going to lesser trochanter. Lesser trochanter is a medial prominence located just inferior to the neck here. Just inferior to the neck, this prominence is the lesser trochanter. It is the insertion point for iliacus and psoas major. Okay, at the tip psoas major and below the psoas major will be iliacus. Okay, so insertion of iliopsoas is lesser trochanter. Okay, understood? Next is intertrochanteric line here. This one is the intertrochanteric line. It is an anterior ridge that obliquely spans the distance between the greater and lesser trochanters, and it is the attachment point for the articular capsule. Capsular ligament is attached over here anteriorly. Okay, and iliofemoral ligament is also attached over the intertrochanteric line. Iliofemoral ligament was connecting the ilium. Okay, ilium with the femur. One of the ligament of the hip joint. Okay, Y-shaped inverted Y-shaped ligament, iliofemoral. Next is medial condyle. Here is the medial condyle of the femur, this prominence. It is a large rounded knob-like projection at the mediodistal end of the femur, articulates with the medial condyle of the tibia. We have discussed. Next is medial epicondyle. See, this prominent part is the medial epicondyle. Okay, medial epicondyle is small medial protrusion superior to the articular surface of medial condyle, and it is an attachment point for tibial collateral ligament. Tibial or medial collateral ligament is attached at this medial epicondyle. Okay. Next is adductor tubercle. It is a small elevation on the superior surface of the medial condyle, and it serves as the attachment point for the adductor magnus muscle. Okay, here on this part, here is the adductor tubercle. Up to this level, attachment of the adductor magnus comes. Okay, so this prominence is medial epicondyle, and over this condyle, this here is the adductor tubercle. Adductor tubercle is very frequently asked Viva question. Okay, you have to show the adductor tubercle and tell its attachment significance. Okay, and also it is asked in your surface marking. Okay, Next is lateral condyle. Here, this one is the lateral condyle. It is a large rounded projection at the lateral-distal end of the bone and articulates with the lateral condyle of the tibia. Okay. Next, we are going to lateral epicondyle. This prominent part of lateral condyle is the lateral epicondyle. So, lateral epicondyle is a small lateral protrusion superior to the articular surface of lateral condyle. It is an attachment point for the fibula or lateral collateral ligament. And next, there is patella surface. This part, anterior part of the articular surface of lower end of femur is the patellar surface. It is the smooth surface that covers the anterior portion of the femoral condyles, and this area articulates with the posterior surface of the patella. Okay. Next, so we have discussed all the specific features visible from anterior aspect. Next, we are going to posterior view. Some will be same, some different are there. Okay. So first is shaft. Shaft is same. Shaft is cylindrical, anteriorly arched body of the femur. Next is the head. Head is also same. It is large, smooth, ball-shaped structure on the proximal end of femur. It fits into the socket acetabulum of the hip at the hip joint. Okay. Next is fovea of head of femur. This is the fovea. It is small pit-like depression on the medial surface of the head, attachment site for ligamentum teres femoris, and this short narrow ligamentous band transmits the arteries to the head of the femur and helps attach the head of the acetabulum of the head of the femur to the acetabulum of the hip joint. Okay. Next, we are going to neck. Neck is also same. Neck shaft angle you must remember. Okay. Neck is a pyramid shaped expanse that connects the head of the femur to the shaft, and it extends laterally from the head at a downward angle of approximately 125 degrees, and it is a frequent site of fracture. 125 degree in adult, okay, and it is more, angle is more in children, 160 degree almost in children. It is normal for there. Okay, but in adult if it is 160 degree, there is coxa valga. Okay. Next is greater trochanter. That will be same. It is a large irregular shaped process located lateral to the neck and superior to the shaft. Greater trochanter. We have already discussed attachments greater and lesser trochanter. Next, intertrochanteric crest. This is different from anterior. So this is intertrochanteric crest. It is a thick ridge that runs obliquely along the base of the posterior neck from the greater trochanter to the lesser trochanter, and it marks the junction between the neck and the shaft. Okay. Next is quadrate tubercle. This one is quadrate tubercle. It is the elevation on the intertrochanteric crest, and that serves as an attachment point of quadratus femoris muscle. Okay. This is a rectangular muscle connected between the hip bone and this quadrate tubercle of femur. Okay. Next is pectineal line. This line is, it is a slight ridge located inferior to the posterior surface of lesser trochanter, and it is an inferior distal attachment site for the pectineus muscle. Okay. So iliopsoas is attached here at this lesser trochanter, and pectineus is attached here at this pectineal line. Okay, so you have got all these muscles in the floor of the femoral triangle: iliaca, psoas major, pectineus. Okay. After that, adductors. Adductors will be attached over this linea aspera. We will discuss. Okay. Next, we are going to linea aspera. See this vertical ridge. Everyone will be asked about this linea aspera. You have to identify linea aspera and its attachment. So linea aspera is a vertical ridge, and that runs along the midline of the femur's posterior surface. Here, linea aspera. And the medial and lateral leaves of the linea aspera are attachment site for all these muscles. Adductor muscles, vastus lateralis, medialis, short head of biceps femoris, that is part of hamstring group of muscles, that these are attached in the linea aspera. Okay. See, this is the attachment of the linea aspera. So first, lateral most. Okay, we will discuss from medial to lateral. Okay, medial most is the vastus medialis. See this red colored one line extending. This is the attachment of vastus medialis. Where is the attachment? You must remember lower part of intertrochanteric line. Okay, then in front of the pectineal line, then extending along the medial lip of linea aspera downward up to this epicondyle. Okay, so this whole of this line gives attachment to vastus medialis. Okay, next there will be one septum, medial intermuscular septum. Next there will be attachment of a pectineus above at the pectineal line and the three adductor muscles. Here is adductor brevis in the upper part, adductor longus in the lower part, adductor magnus along the whole length. Okay, a linear extension, and it will be extended up to this adductor tubercle. Okay, so this is attachment of adductor magnus, and there will be hiatus formation. 5 hiatuses are present along the attachment of the adductor magnus. Okay, so these are the adductor group of muscles. After that, you will see one septum, that is posterior intermuscular septum. So this is adductor magnus. After this, the green line, this is posterior intermuscular septum. Okay, next we are going to other compartment, hamstring compartment. Hamstring, one single hamstring muscle is attached here, short head of biceps femoris. Others are originating from the ischial tuberosity. Okay, origin from ischial tuberosity is a feature of hamstring group of muscles. So this is by short head of biceps femoris. After that, another intermuscular septum, lateral intermuscular septum. The green line represents the lateral intermuscular septum. After that, most laterally is the attachment of the vastus lateralis. And where the vastus lateralis is attached, it is attached here in the upper part of intertrochanteric line, then on the anterior and inferior aspect of this greater trochanter, then on the lateral side of gluteal tuberosity, and then extending downward along the lateral lip of the linea aspera up to this condyle, epicondyle. Okay, so this whole extent is the attachment of the vastus lateralis origin. Okay, and insertion of all this vastus will be over the patella. Okay, base of the patella. Okay, so linea aspera, we have discussed attachment of all these structures. So from medial to lateral, vastus medialis, then medial intermuscular septum, then pectineus, adductor brevis, adductor longus, adductor magnus, then posterior intermuscular septum, then short head of biceps femoris, then lateral intermuscular septum, then vastus lateralis. Okay, so these are the attachment of linea aspera. You have to tell these all these in sequence. Okay, from medial to lateral you remember, or from lateral to medial according to your convenience. Okay, next is gluteal tuberosity. See, this part is the gluteal tuberosity. Gluteal tuberosity is a roughened vertical elevation that extends from the top of linea aspera to the base of the greater trochanter, and it is an insertion point for the gluteus maximus muscle. Okay, so here is the 1/4 fiber of gluteus maximus are inserted over this gluteal tuberosity and rest 3/4 into the iliotibial tract. Okay, next is medial condyle. Here this one is the medial condyle. It is a large rounded projection at the mediodistal, we have already discussed, forming the knee joint. Lateral condyle is also can be visible from posterior aspect. Intercondylar fossa. Okay, this fossa you can see from posteriorly. This is intercondylar fossa. It is a large notch between the posterior part of the condyles, and that provides space for the cruciate ligaments. Okay, and that help attach the femur to the tibia at the knee joint. Okay, next medial epicondyle we have already discussed. Medial epicondyle, lateral epicondyle. So protrusion above the medial condyle, attachment point for tibial collateral ligament. and helps attach the femur to the tibia at the knee joint. Next is adductor tubercle. Here is the adductor tubercle. It is a small elevation. Here you can see the adductor tubercle. Okay, here is the adductor tubercle. So it is a small elevation on the superior surface of medial condyle, and the vertical fibers of the adductor magnus muscle attached to this prominence. Okay. Next is lateral epicondyle, is a small protrusion above the lateral condyle, an attachment point for fibular collateral ligament, and helps attach the femur to the tibia at the knee joint. Okay. Next is lateral supracondylar line. These are supracondylar lines. This is medial, this one is lateral. Okay. So lateral supracondylar line is the inferior extension of lateral lip of Linea Aspera, extends at the lateral epicondyle up to the lateral epicondyle, and the rees is the attachment site for vastus lateralis, piriformis, and biceps femoris. Okay. Next is medial supracondylar line, this one. It is an inferior extension of medial lip of Linea Aspera, terminates just above the adductor tubercle, serves attachment point for inferior portion of vastus medialis, adductor magnus. Okay, we have discussed their attachments. Next we are going to anatomical position. Okay, and here will be attachment of gastrocnemius on this popliteal surface. Okay, medially medial head of gastrocnemius, laterally lateral head of gastrocnemius, and here will be attachment of the plantaris muscle. Okay, in the popliteal surface these three muscles are attached, and on the lateral surface of the lateral condyle, here groove you can see, this groove is for the popliteus tendon. Okay, popliteus muscle originates from the anterior aspect of the groove, and the tendon is lying in the groove, and it is inserted on the posterior surface of upper end of tibia, popliteus muscle. Okay. Next we are going to the anatomical position and side determination. Side of the femur is determined by holding the bone vertically in such a way that the head faces upward, medially, and slightly forward. If you place your index finger just below the head, it will come in anatomical position. Okay, so head is directed, you can see, upward, medially, and slightly forward. Okay, and long axis of the shaft, you can see, long axis of the shaft is directed downward, medially, and convexity of the shaft is placed anteriorly. Okay, and lower surface of both the condyles are in same horizontal plane. This lower surface of both the condyles in the same horizontal plane. Okay, so how will you, so these are the articulation and anatomical positions. Okay, next, so the anatomical position can be achieved by balancing the neck of femur on your index finger. Okay, like this. And next is neck shaft angle. This is very frequently asked in your Viva. Okay, and if you for honors question, this is asked, angle of femoral torsion. Okay, so angle of inclination of femur, it is the angle between the long axis of neck and shaft of femur. This is long axis of neck, and this is long axis of the shaft. In between these two lines, this angle is the neck shaft angle. Okay, this is 125 degree in adult and 160 degree in children, and it is less in female, more, less than males. Okay, next is angle of femoral torsion. This is angle of femoral torsion. It is the angle between the long axis of the head and neck of femur and the transverse axis of femoral condyles. Okay, so how will you see it? You make a axis in between the head and neck. Okay, another axis is placed here, transverse axis, and you see like this. Okay, so these two axes will form a angle. So this angle, you can see here, it is being formed. This is head and neck, and this is condyles. Two axes are forming an angle from 7 to 12 degree. Okay, that is angle of femoral torsion, angle between long axis of head and neck of femur and transverse axis of femoral condyles. It measures about 7 degree in male and 12 degree in females. Okay. So these are the borders and surfaces. Borders are not much prominent. Only the linea aspera or posterior border is very much prominent. So see in the middle 1/3 we have already discussed. Middle 1/3 3 borders. This is posterior border, medial border, lateral border, and 3 surfaces are anterior surface, medial surface, lateral surface. So middle 1/3. For upper 1/3, there is 4 borders and 4 surfaces. Okay, first one is medial border, lateral border, and here is the spiral line, or you can say pectineal line, and gluteal tuberosity. Okay, and surfaces are anterior surface, medial surface, lateral surface, and posterior surface. Okay, so 4 surfaces in the upper 1/3, and in lower 1/3 also 4 borders and 4 surfaces. 4 borders are, here is the medial border, lateral border, medial supracondylar line, lateral supracondylar line. So anterior surface, medial surface, lateral surface, and this popliteal surface or posterior surface. Okay, so these are the borders and surfaces. Okay, see those attached. Anterior view, posterior view, intertrochanteric line, intertrochanteric crest, quadrate tubercle, posterior surface, spiral line or pectineal line, gluteal tuberosity. This is popliteal surface. 2 supracondylar lines, intercondylar fossa, adductor tubercle, linea aspera. Okay, and here is patellar articular surface. Pit or fovea. Okay, head, neck, greater trochanter, lesser trochanter. And these are the muscle attachment. On the anterior surface, upper 3/4 gives attachment to the vastus intermedius. And here is the attachment of vastus lateralis, vastus medialis. These are the extensions of the vastus lateralis and medialis. We have already discussed. And just below the vastus intermedius, here is attachment of articularis genu. Okay, 2 to 3 fibers are present, and it keeps the synovial bursa in position. Okay, synovial bursa of the knee joint, which is projecting anteriorly, and this genu, articularis genu, other end is attached to this synovial bursa. And here are the attachment we have already discussed. Lesser trochanter psoas major, greater trochanter piriformis, gluteus minimus, anterior surface. And here is the quadratus femoris. Here is gluteus maximus over gluteal tuberosity, psoas major, pectineus, adductor brevis, longus, adductor magnus. Okay, here is the medial head of gastrocnemius, plantaris, lateral head of gastrocnemius. Okay, and here is the gluteus medius on the oblique ridge on the lateral surface of greater trochanter. And here in the intertrochanteric fossa, obturator externus. And you remember the capsular ligament is attached anteriorly over the intertrochanteric line. Okay, and posteriorly it is attached 1 centimeter above the intertrochanteric crest. Okay, here it is not along the intertrochanteric crest. And the retinacular vessels we have discussed supplying the head and neck of femur, it is passing just beneath the capsule. Okay. Okay. And see here the attachments of anterior and posterior cruciate ligaments at the lower end in the intertrochanteric fossa. And this is attachment of the capsular ligament of knee joint. This is along the articular margin. Okay. No difference is present. This is attachment of linea aspera we have already discussed. You must know this. Okay. All the muscles or structures attached over the linea aspera, and you tell them in sequence, not haphazardly. Okay, and this is attachment of upper end. This is pit of fovea, ligament of head of femur, and this is on the superior surface of the greater trochanter. At the tip there is piriformis, then tricipital tendon, gemellus inferior, then obturator internus, and then obturator gemellus superior. Okay, they are forming the tricipital tendon, and here in the trochanteric fossa obturator externus. And this is anterior surface. Here is the gluteus minimus, lateral surface, oblique ridge, gluteus medius, and rest of the area is covered by bursa, trochanteric bursa for gluteus medius. Here is trochanteric bursa for gluteus maximus. Okay. Next, we are going to the ossification. Primary center of ossification appears in the middle of the shaft of femur at 7th to 8th week of intrauterine life. And secondary center for the upper end, 3 in number. First, for the head appears at 1 year of age, for the greater trochanter at 3 years of age, and for lesser trochanter at about 13 years of age. Okay, and these 3 epiphyses fuses with the shaft separately at about 18th year of age. Okay, and for lower end, the epiphysis appears at 9 months of intrauterine age, that is just before birth of the child. Okay, and it has a clinical significance, and it fuses with the shaft at 20 years. So lower end will be the growing end of the femur. So what is the clinical significance of lower end? The secondary center at the lower end of femur is unique in sense that it appears during birth or just before birth at 9 months of intrauterine life, and hence it has medico-legal importance to determine the age of the stillbirth child. Okay, newborn baby found dead was full term or viable. Okay, if it is present, this epiphyseal center is present. If you see in the X-ray plate, here you can see epiphyseal center is present. So hence it is a medico-legal importance because its appearance in radiograph indicates that newborn baby was found dead, was full term and viable. Okay, child could live. Okay, in case of death of child. Fracture neck of femur we have already discussed. Trochanteric fracture also we have discussed. Those are important for femur fracture. Okay? And these are the articular surface for tibia, articular surface for patella, and this is upper end of tibia. Will articulate to form the knee joint. Here are the cruciate ligaments, knee joint. Okay, and in the knee joint is a complex joint because articular cartilaginous plates are there, C-shaped cartilaginous plates, and these are known as meniscus. Here laterally lateral meniscus, medially medial meniscus. Okay, and these are the in the intercondylar area there will be attachment of this cruciate ligament. Here is anterior cruciate ligament, posterior cruciate ligament. Okay. So lateral wall of the trochanteric fossa attachment of anterior cruciate ligament, and medial wall of trochanteric fossa attachment of the posterior cruciate ligament. That's how you remember. Okay. And other ligaments are also there, medial or tibial collateral ligament, lateral or fibular collateral ligament, transverse ligament. Other ligaments are also present in the knee joint. Knee joint will get long question. Okay, and he will have lecture class. Next we are going to patella. So we have completed femur. Okay, patella is the triangular shaped bone. Okay, here you can see this is patella. Okay, it is a triangular bone that covers and protects the distal surface of the anterior femur, and it is located directly. Why are you talking? Silence everyone. So it is located directly anterior to the groove between the femoral condyles called the patellar surface. You have already seen, here is the patellar surface at the lower end of the femur, this part. Okay, and 2 facets or depression on the posterior side of patella articulate with the medial and lateral femoral condyles. See, these 2 facets will articulate at the lower end of the femur, at the patellar articular surface. Patella is embedded in the quadriceps tendon. It is formed in the quadriceps tendon. This is a sesamoid bone, which makes it the largest sesamoid bone in our body. This is asked in your Viva and MCQ. patella is the largest sesamoid bone formed in the tendon of quadriceps femoris. Okay, and it functions to displace the tendon away from the femorotibial joint surface, and this increases the lever arm of the tendon and the tension applied to the tibia when the knee extends. Mainly helps in knee movements and protects the knee anteriorly. So what will be the anatomical position and side determination? Only this is asked about patella, and muscle attachments are asked. Okay. So hold the patella in such a way that its apex faces downward and its base faces upward. See, this projecting part is the apex. Apex, and on the posterior surface of the apex there is a rough area. Okay. So this is apex. It you replace the apex downward, and base is directed upward. Its articular surface faces posteriorly. This flat, smooth surface, articular surface placed posteriorly, rough surface is anterior, rough convex surface, and large lateral part of articular surface determines the side. Okay. There is a ridge which divides the smooth articular surface into two parts, large lateral part and small medial part. Okay, so place the large part laterally and keep the articular surface of patella on the tabletop in such a way the base is directed towards you and apex is away from you. Now observe the tilt of the patella, and patella as a rule tilts towards the side it belongs. Okay, so you place the patella on a flat surface. I am placing it here. Apex is away from me and base is towards me. Okay, and if it is tilting towards the right side, so this is right patella, and this patella you can see here apex is here, rough area. So apex away from you. If you place it in the flat surface, it is tilting towards the left side. So this is left patella. Okay, so that's how you determine the side. In bones Viva table, you have to determine the side and hold it in anatomical. Hold it with your hand, single hand near the apex. This is anatomical position of the patella. Okay, right patella. At a left patella, you hold it with your left hand. Left patella. Okay, understood. Next, the attachments. See, near the base of the patella, four muscles of quadriceps femoris are attached, most anteriorly rectus femoris, then in the same plane vastus lateralis, vastus medialis. And you can remember vastus medialis extend downward more than the vastus lateralis. Okay, occupies the upper 2/3 of the medial margin, and it occupies only upper 1/3 of the medial margin of the patella, and posteriorly lies the vastus intermedius. And at the apex of the patella, the rough area gives attachment to ligamentum patelli, which is going to attach at the tibial tuberosity. Okay, and see, this is the anterior view, this rough area, and there are some nutrient foramens, irregular area for attachment for the quadriceps muscles. Muscle fibers are attached here. Here is the base directed above, apex is directed downward, lateral border, medial border, and this is anterior surface, and this is posterior surface. Near the apex there is a rough area, and this whole part forms the articular surface, which is divided into two areas, larger lateral area, a smaller medial area. Okay, and this articular surface again divided by a small part is separated, which comes in contact with femur only in full flexion of the knee. Okay, and rest of the part is divided by two horizontal lines into three separate areas. Upper areas comes in contact with the patella during ordinary knee flexion, middle areas during semi flexion of knee, and lower areas ordinary knee extension. Okay, so these are the areas coming in contact with femur, and here muscle attachment have been shown: rectus femoris, vastus lateralis, vastus medialis, vastus intermedius, ligamentum patelli. Okay, this is base, apex, anterior surface, posterior surface. Articular area is divided by a ridge into medial small facet, large lateral facet, rough area near the apex. Okay. So base is broad convex superior margin of patella, serves as attachment point for quadriceps tendons. Apex is the pointed inferior margin of patella, and this region serves as attachment point for patellar ligament, which is an inferior extension of quadriceps tendon. Lateral articular facet is then large of two shallow depressions on the posterior surface of patella, articulate with lateral condyle of femur, and medial articular facet is smaller and two shallow depression on the posterior surface of patella, which articulates with the medial condyle of the femur. Okay. Next, we are going to ossification. Patella ossifies from several centers which appear during 3 to 6 years of age of the child and fuse quickly to form a single center, and the ossification of patella is complete at the puberty. Okay. Next, some clinical aspects. Abnormal ossification of the patella. Abnormal ossification centers in the patella may form 2 or 3 separate pieces of patella called bipartite or tripartite patella. Okay, that means these multiple centers are formed. These centers are all not fusing together. Okay, some are staying separately. They are forming separate bone, and this condition can be differentiated from fracture of patella as it is bilateral. Okay, bipartite or tripartite condition is bilateral, and the pieces have smooth margins. In case of fracture, there will be rough margin. Okay, fracture patella is also very common condition. Next is dislocation. Dislocation very commonly occurs during football or so the patella has natural tendency. This comes in your explain why question. Very important explain why question. Why patella dislocates laterally? Okay. Patella has natural tendency to dislocate laterally due to upward and lateral pull by the quadriceps. And you have seen the attachment of vastus lateralis is not much, only extending upper 1/3 of the lateral margin. But extent of vastus medialis is up to upper 2/3. Okay, so extent is more. However, it is countered by 3 factors: more forward projection of lateral femoral condyle. These factors prevent dislocation. Okay, more prolonged insertion of vastus medialis to the medial border of patella than that of vastus lateralis on the lateral border, and medial pull exerted by medial patellar retinaculum. Okay. The rest of the portion, patellar borders, medial and lateral borders, they are giving attachment to fossal extension. Those are known as patellar retinaculum. Okay, laterally lateral patellar retinaculum, medially medial patellar retinaculum. Next is we are going to fracture of patella. A direct blow on the patella fractures it into 2 or more pieces. A sudden or forceful contraction of quadriceps femoris causes a transverse fracture of the patella, and the patella being a sesamoid bone, it is devoid of periosteum, hence when fracture bony union does not take place. Okay, you have to do wire fixation, circumferential wire fixation of the patella. There will be no healing because it has no blood supply. Sesamoid bone. Okay, that's all. So you will be able to hold femur and patella in position, anatomical position, and clinical aspects are important for explain why. Okay. So these 2 bones very commonly given in your Viva table, axial skeleton.